Hi friends. In this video, I will describe side effects of steroid use. These are extension of the pharmacological action occurring with prolonged therapy, and are a great limitation to the use of corticoids. 1. Mineralocorticoid side effects: sodium and water retention, edema, hypokalemic alkalosis, and a progressive rise in BP. These are now rare due to availability of highly selective glucocorticoids. Gradual rise in BP occurs due to excess glucocorticoid action as well. 2. Cushing's habitus, characteristic appearance with rounded face, narrow mouth, supraclavicular hump, obesity of trunk with relatively thin limbs. 3. Fragile skin, purple striae, typically on thighs and lower abdomen, easy bruising, telangiectasis, hirsutism. Cutaneous atrophy occurs with topical use also. 4. Hyperglycaemia, may be glycosuria, precipitation of diabetes. 5. Muscular weakness, proximal, shoulder, arm, pelvis, thigh, myopathy occurs occasionally. 6. Increased susceptibility to infection, this is nonspecific, latent tuberculosis may flare, opportunistic infections with low-grade pathogens, candida, etc., may get activated. 7. Delayed healing, of wounds and surgical incisions. 8. Peptic ulceration, risk is doubled, bleeding and silent perforation of ulcers may occur. 9. Dyspeptic symptoms are frequent with high-dose therapy. 10. Osteoporosis and avascular necrosis, specially involving vertebrae and other flat spongy bones. Compression fractures of vertebrae and spontaneous fracture of long bones can occur, especially in the elderly. Radiological evidence of osteoporosis is an indication for withdrawal of corticoid therapy. Avascular necrosis of head of femur, humerus, or knee joint is an occasional abrupt onset complication of high-dose corticosteroid therapy. 11. Posterior subcapsular cataract may develop after several years of use, especially in children. 12. Growth retardation, in children occurs even with small doses if given for long periods. Large doses do inhibit growth hormone secretion, but this may in addition be a direct cellular effect of corticoids. 13. Pregnancy-related complications and fetal abnormalities. Cleft palate and other defects are produced in animals, but have not been encountered on clinical use in pregnant women. The risk of abortion, stillbirth or neonatal death is not increased, but intrauterine growth retardation can occur after prolonged therapy, and neurological or behavioral disturbances in the offspring are feared. Prednisolone appears softer than dexa or beta-methasone, because it is metabolized by placenta, reducing fetal exposure. Prolonged corticosteroid therapy during pregnancy increases the risk of gestational diabetes, pregnancy-induced hypertension and preeclampsia. 14. Psychiatric disturbances. Mild euphoria frequently accompanies high-dose steroid treatment. This may rarely progress to manic psychosis. Nervousness, decreased sleep and mood changes are noted by few. Rarely a depressive illness occurs after long-term use. 15. Suppression of hypothalamo-pituitary-adrenal, HPA, axis, occurs depending both on dose and duration of therapy. In time, adrenal cortex atrophies and stoppage of exogenous steroid precipitates a withdrawal syndrome including malaise, fever, anorexia, nausea, postural hypotension, weakness, pain in muscles and joints and reactivation of the disease. Subjected to stress, these patients may go into acute adrenal insufficiency. Measures that minimize HPA axis suppression are: use shorter-acting steroids, hydrocortisone, prednisolone, at the lowest possible dose. B. Use steroids for the shortest period of time possible. C. Give the entire daily dose at one time in the morning. D. Switch to alternate day therapy if possible. E. If appropriate, use local, dermal, inhaled, ocular, nasal, rectal, intrasynovial, preparations of a steroid with poor systemic availability, beclomethasone, triamcinolone acetonide, fluticasone, etc. Thank you for watching this video. Please like, subscribe, share and hit the bell icon for more such videos.